All right. Good evening. Thank you, Khalid. We have a very interesting session that we're going to start soon. It's integrating imaging and physiology in intervention, case-based insights. We have very nice panel here. We have a panel of experts. There is only disclaimer. This session was actually organized by Fawaz al-Bardouni. Unfortunately, he wouldn't be able to here today. Him and Hani did massive work in organizing this. I just took over and added chips and tips here and there. We're going to learn from the very best, both in the field, but both from internal in the Gulf and from outside. We have Adil Jabri here from Oman. We have Ahmed al-Shiri, who couldn't join us today. Ashraf al-Azouni, who's my senior fellow when I was training as well, and he's doing very well in Cleveland Hospital. And we have Hani Abdul Hadi, and we have Ziad Ali, and we have Carlos Collet, who's my co-chairman. And to be honest, I'm here to learn here today from the whole panel, so I guess you will learn as well with me. So without further ado, I think we could start with physiology and borderline lesion with Dr. Carlos Collet, who's going to guide us through this.
So thank you for the introduction. And the way that we're going to do this, we want to have a very interactive session. So that's a bit the point. Hani will present a case. The intention is that we all discuss a little bit more what is happening, what are the pros and cons of every decision. And as you mentioned, we have a very good panel. We have a very good team for the discussion. And the cases have been prepared since very few long weeks, and we have done our best to make this as educational as possible, so we hope that you enjoy. Hani, I think you can start with the first case.
Fantastic, thank you. So, this is case-based learning. So the first case is a 78-year-old gentleman, one of our typical patients, so diabetic, hypertensive, and dyslipidemic, and has peripheral vascular disease. So this patient comes in with acute pulmonary edema and has to be intubated as an emergency in our ER. There's very little history from the patient, but we know from his companion that he had some kind of chest discomfort prior to his pulmonary edema. His ECG shows a left bundle branch block. We have no previous ECGs for this patient. His systolic is 200 millimeters of mercury. That may or may not be important. And an emergency echo showed no obvious wall motion abnormalities and no major aortic dissections or issues. So we thought this is a potential STEMI and took him to the cath lab as soon as he was intubated and ventilated. This is the coronary angiogram. So we can see here that it's mostly a left dominant system. There is some disease in the LAD, but there's TIMI3 flow everywhere. This is not clearly a STEMI. We did an LV gram. The EDP was slightly high, but we did an LV gram, and he has normal left ventricular function. So at this stage, we know nothing about this patient. He's elderly. He's just had a pulmonary edema. We don't have any lab work. We don't have any data, and there's TIMI3 flow. So I stopped, because you don't know what's going on. His creatinine might be a lot high. He might have a high potassium. This might be hypertensive heart disease. We're clueless. So we stop. He's safe enough to stop. We take him off the table. He goes back to CCU, eventually extubated and weaned off. Stable. Initiate medical therapy. His LV function is fine. And there's a mild troponin rise, but nothing very special. And we thought maybe this is hypertensive heart disease. Let's treat him medically, do some outpatient ischemia testing, and then follow him up. However, a month and a half later, he comes back to ER again with acute flash pulmonary edema despite medical therapy. Same left bundle branch ECG. So this time we didn't take him straight to the cath lab. We said, hold off. We treated him medically, offloaded him, extubated him, and then took him electively to the cath lab. On this occasion, I thought, let's further assess this LAD. And we did a pressure wire assessment, and the IFR distally is 0.81. So we do an IFR pullback, and this is the image that we get.
Very nice.
Now, we bring him, we start doing an IVUS interrogation, and the ostium of the left main has an MLA of of the LAD has an MLA of 3.4 with a distal reference area of 15. So there's critical ostial LAD that wasn't very obvious angiographically. You'd never guess that was the case, but we did IVUS guided stenting with a single drug-eluting stent, did it provisionally from LAD to left main with an excellent result. Briefly, our second case is a 55-year-old gentleman with stable angina, hypertensive diabetic, has got anterior ischemia on his myocardial perfusion scan. And we do this coronary angiogram. So you've got this dominant right coronary with no significant disease. There's mild disease in the circumflex. And this, to me, angiographically, Looks like mild to moderate LAD disease. Doesn't really look critical, but again, we assess this with a pressure wire. And our distal IFR is 0.85, and this is our pullback measurement. So these are our two cases. This case we treated medically. And here we'd stop and pause and ask for Dr. Carlos to come over and talk us through these two cases, and then maybe give us a presentation.
So, Hani, you have, let's wrap it up. You have two cases. Have this on? Good. You have two cases. Both cases, the disease is hemodynamically significant. The IFR in both cases is below 0.89. But clearly, the first case is spectacular because, you know, it looks like a lesion that you cannot see in angiography, although after you show me the IFR, I look at the angiography again and say, yeah, you know, yeah. Now I can see it. But I understand that the first thinking process on, yeah, this is not really a case for anything in that acute setting. So let's look at this pullback curve, and I have shown some animations that I'm going to show it again, but I think with these two cases, what is important to analyze is the following. When we look at this pullback curve, and we're going to start with the one on the left, we see that there is a gradual decrease in flow, we can say flow or pressure, in the mid part of the vessel. And you can either see that either in the pullback curve or looking at the dots in the angiogram. And you clearly see here the big step in the left main with that you show that correlated with IBUS as well. Now, that is what we call focal coronary artery disease from the functional point of view. On the right side, you see exactly the opposite. You can either see with the points, with the dots, that you see a evenly distributed amount of pressure losses, but you don't see any step up in the curve. And this is, I think I fully agree with what you have decided in your cath lab, despite having a positive IFR. And I think I showed this before, we can show it one more time, is that using physiology in a very comprehensive way, and you're doing that in your practice, which is basically trying to understand more what is the disease of the patient. And we have shown this animation to explain what are the consequences of PCI in focal and diffuse disease. And I'm going to show this very quickly. That is the fact that when you have focal coronary artery disease, there is a clear step up in the pullback curve that you have shown with your IFR tracing. And these are the best cases for PCI, because when you put the stent, and you have shown that in your case, this really alleviates the problem at the epicardial vessel, and the flow is completely restored, as you see in the slide. Now, you didn't do the PCI in diffuse disease, and I think you were completely right. And the reason is that when we do PCI in diffuse disease, and this is all new, we didn't know this was a problem so important, but when we do PCI in diffuse disease, we actually don't improve flow at all. At the most, we can get a small increase in flow, but this is not sufficient. The patient remains symptomatic. So I think you have done, state-of-the-art clinical decision-making with physiology and state-of-the-art PCI treatment with imaging. And we can stop here and have a short discussion. See, any comment from your side, in terms of what was done in the cath lab, and again, the whole rationale theoretical behind it?
I think the first thing is we saw the disease in the first case with this LAD disease, but we didn't really think it was that significant. Not enough to cause the presentation that came in, but sometimes the angiogram fools you, right? We do this thing in our cath lab, is we take bets from everyone. What do you think the FFR or the IFR is going to be before you do it? And sometimes you can't guess. Sometimes you can swear you're going to stent the vessel and it's negative. So I think it's very important to know physiologically before you go anatomically. The second case with diffuse disease was an issue. I mean, there are times where we've seen these stented, and that's the worst thing you can do, which is a full metal jacket and an LAD, where there's no benefit to the patient. So I'm quite happy with the decision making for both sides.
So I think for me the message here is, when you have a symptomatic patient and you have ambiguity, the pressure wire resolves that ambiguity, not only as to whether you should treat based on an IFR, but also to treat or not based on the pattern of disease. Remember, all of these are really not prognostic implications. The goal here is to improve the patient's symptoms, right? And so to improve the patient's symptoms, Carlos has shown very nicely that people who have focal disease have a much bigger delta in the FFR or IFR, and as a result get a much better improvement in symptoms, and patients with diffuse disease just simply don't get that. And that's why the therapy is optimized really by medicine, If you think of this conceptually, it makes perfect sense because the amount of plaque or vasculopaths that happens in diffuse disease fits with every CT study that we've come across, right? The more plaque you have, the more likely you are to die.
Yes. And I think, to be honest, I congratulate you on picking up the case. I think many places will just call it a HFpEF. That's it. So this is actually a non-coronary case. This is just HFpEF. Let's give some Lasix and discharge the patient without actually doing the IFR and FFR for the case. Anything from you?
Yeah, so very nice case, Hani, you present. So just one question. When the patient came actually the first time, pulmonary edema, everybody will think this is left main, kind of disease. And we saw that the image, there was some kind of distal left main, but in the IVAS, there was only ostial LAD. So I don't know whether, did you interrogate the circ as well from left main to circ just to see if there's any disease, because twice pulmonary edema, although ostial LAD, it's maybe kind of left main equivalent disease from the clinical presentation. I was wondering whether the ostium of the circ was fine.
I didn't actually. I didn't think angiographically I wasn't attracted. Maybe I should have, but I didn't. I interrogated the RCA, which is possibly non-dominant, but the IFR was 0.95 or something. The other question I've got, if I can, to Carlos. This guy with lengthy diffuse disease, would a lima help him or no?
Yeah, that's a very good question. And Ziad, you mentioned something that, when we started discussing this, and I think you were a few years ago, and Alan, Jeremiah was also involved, we said, okay, what happened when you have these diffuse pressure losses? And there were basically two opinions. The first one was treated medically. There is no target for PCI, you will not increase the flow. And then I remember Alan saying to me, Carlos, you have to put 2 long 48s, use IVUS and OCT, make your MSA the best you can, and you're going to restore flow. And okay. So we said, well, there's no data. So I think these are the two options. Now, what we have kind of discovered doing all these trials, and we just presented PPG Global, is that we cannot fix diffuse disease with PCI. These patients, despite having long stenting, optimal stenting by imaging criteria, they remain to have diffuse pressure losses with positive physiology distally. So now, what to do with them? That's your question. And honestly, the honest answer is we don't know. What we do know is that in patients with diffuse pullback curve, if you look at the experience in Japan, they started sending these patients to surgery. What the Japanese have reported is that when you put a lima in these LADs, the chance of the lima failing in 1 year is about 20%. 20%, that's a single center experience, small number of patients. So we still need to know how to do this, how to do these cases better. Of course, now you have drug coating balloons, that might be an option. We know that long stenting with metallic stents perhaps is not the best solution, but I think today medical therapy looks like a reasonable first selection for treatment in these patients.
So let me ask you something on that. Because by theory, if you do put 2 long stents, theoretically you should increase the flow, right? That's just the physics. So what is it that's stopping the patients from getting the clinical benefit if you're actually improving the flow?
Well, I have to say the following. When Bernard de Bruijn and Nico Pils started writing about FFR, they wrote in a lot of places, after a perfect stenting, FFR should be 1. That's written. You have the reference. So then we started looking at these cases, why the FFR is not 1? And I'm going to be honest with you, see, again, we don't know. We don't know, but we have in PPG Global 1,000 patients, diffuse disease, treated with imaging, long stents, doing everything the best you can. You simply cannot increase the flow. It appears to be, in my hypothesis is there's a phenomenon related to the diffuse atherosclerosis plus vessel size. So this is, again, some of the limitations that we're starting to understand about diffuse disease. And I think we're just starting. This field is just starting.
Let me ask you that, since you are a pioneering site in measuring the absolute flow. So if you have very diffuse disease, are you maximally vasodilated in your microcirculation? Because you have so much disease, you have an inability to augment flow. As a result, your microcirculation is already vasodilated. So when you put in stents, you can't increase the flow anymore. It's already high. So your rest flow is high.
So that's a very nice. And what you're referring to is a new way to measure blood flow in the coronaries. It's called absolute flow. You need to have something called the ray flow infusion catheter, and you can measure absolute flow in milliliters per minute and absolute resistance in Woods units. This is completely new. Okay. Now, what we have discovered is that when you measure CFR in focal and diffuse disease is different. And this, again, completely the opposite as what has been reported by Lance Gould and Nizzy Johnson. That's very nice. What we're seeing is that CFR in focal disease is very low. And CFR in diffuse disease is, I would not say normal, but not so low. So it's the opposite that was thought at the beginning. At the beginning, it was thought that CFR will be lowest in diffuse disease. It is not. The second thing that we have found is that there is no relationship between the pattern of epicardial disease and the presence of microvascular dysfunction.
That I agree, yeah.
There is one study, everybody say diffuse disease is linked with microvascular disease. There is one IVUS study linking that of 43 patients. That's the only thing in the literature. This is why we said that. We have been looking at that. But we have found zero association between diffuse disease and microvascular disease.
I have a question. I just wonder, because many of the cases where we find diffuse lung disease in the proximal to middle ED and so on is where we send them to CABG, as you mentioned, and somehow Lima actually does well long term. So I'm not sure, will be there any difference in mechanism or hemodynamics when it is a Lima versus PCI? Why would they benefit with one versus the other? Is there any explanation for that?
Or they don't benefit from either.
Yeah. I mean, this particular patient did well on medical therapy, actually. We just intensified his tablets. And technically, you can argue it's not left main proximal LAD multivessel disease where revascularization makes you live longer. But I suppose, what if he is on maximal medical therapy and doesn't improve? I suspect you can put a coronary sinus occluder, or maybe you just leave the coronaries alone, eh? Or debit. I don't know. I've not seen much data about lengthy diffuse debbing.
If I may jump in, I don't know. In case of diffuse disease, maybe we are not doing a good job in terms of stenting, because maybe we are just stenting, whatever we are seeing angiographically, and you are not treating the full disease segment. Maybe this is why the Lima as a long term is better in this case, beside what Dr. Collett was saying about microcirculation. Also, this is maybe something to add.
So for all of us, I think that this is a new frontier of PCI. We have now, for us in the cath lab, what is now is very easy to detect diffuse disease. You just put your wire distally, you make a pullback, you see that there is positive distally, and then you see no real focal pressure loss, despite whatever angiographic appearance that you have. So that is new. And then for us is now searching what is the best strategy. It might be medical, might be surgery, but I think this is the current state of knowledge.
The sad part about the medical therapy is that all of the CT data shows that these people just die, right? Because plaque volume and total atheroma volume is tied to mortality, which makes sense, right? They have disease everywhere, in their carotids, in their peripheral vascular disease, in their mesentery, everything. And so it's a real therapeutic dilemma about what to do, and if anything, for these people who are just riddled with atherosclerosis. And obviously driving their LDL into the ground is of paramount importance, but do we have device-related therapeutic interventions? Maybe it's a coronary sinus occluder, something that's going to bypass the current volume of atherosclerotic plaque that we can't get around.
Great discussions, guys. We have a question from the Dr. Musa Akbar.
Yeah, just I want to ask, what is the definition of focal lesion versus diffuse in terms of the length? So if there are focal lesion in couple millimeter, 310 is focal lesion. So what is the definition that you say that this is a diffuse lesion that if I will put a stent, I'm not going to gain benefit in terms of FFR?
Okay, so that's a very good question, and that's the very question that drove us to develop PPG. And the reason is there is no standardized diagnostic criteria to say what is focal and what is diffuse. So the definitions everything that we're talking here in the panel refers to physiologically diffuse disease. In other words, pressure pullback without any pressure drop, and that can be now quantified by PPG, We have this metric of PPG we were discussing yesterday. The next trial is going to use a cutoff of 50. Less than 50 we will not treat. Even with positive physiology, let's call it that way, more than 50 is a case for PCI. And this is how we see the field moving forward.
Yes, please.
Yeah, I have a question. So, we do know, I think, from the subset analysis of target FFR, that diffuse lesions, if you were going to do a post-PCI physiology, diffuse lesions have much less incidence of IFR of greater than 0.9 or 0.89. But it is not a all or none phenomenon. There are some people whom you do get benefit and it normalizes. So I don't think we want to throw the baby out of the bathwater and say that none of these should be treated. I think I agree we are in a sort of a gray zone now because with all the data which Dr. Collett has presented, but I think a call for a greater post-PCI physiological assessment should, I think, be at the first place, which is really being done in a minuscule population right now. I think that's where we'll start getting more insight into our diffuse population.
That's a great comment. And well, I have to tell you that we analyzed the data of target FFR. We did a core lab for that trial. And what I can tell you about post-PCFFR is just a marker of the disease that you had at baseline before you put the stent. If you have diffuse disease, you will have low post-PCFFR. If you had focal disease, you will get high post-PCFFR. That's what we learned from target. Now, the data that Siad was referring to in terms of angina improvement is from target FFR. So that is the sub-analysis of target FFR of the patients that had pullback before the procedure. And in that specific trial, this is in the appendix of the paper, we saw that patients that had a PPG before 50, none of them improved the Seattle Angina Questionnaire more than 5 points.
So you're saying key is PPG. PPG is the most important.
Yeah, and I think Carlos will show you on a few slides later on exactly what the PPG looks like and what it means so that you can all have a greater understanding. I mean, in my opinion, this metric is going to become as important as FFR or IFR cutoff values. Because ultimately, we're looking for a decision to treat in order to benefit patients. And we've seen the data for FFR, we know the data for IFR, but we're missing on this diffuse disease algorithm. And now since we have PPG, we'll be able to make a clinical decision as to whether or not patients will benefit from PCI based on whether it's diffuse or focal.
We will move with the slides and then we'll continue in the discussion, I think. Hani, if you want to continue.
Yeah. Shall we go to the second case? Yeah. So the second case of interest is the utilization of physiology and imaging in bifurcation cases. Here we present a 68-year-old patient, diabetic hypertensive, ex-smoker, who came to our hospital with a non-STEMI, anterior T-wave changes and preserved LV function. So the right coronary artery is dominant with mild to moderate non-obstructive disease. And I'm just going to play the angiogram for the left coronary system. Yeah. So I'll let this run for a couple of loops for everyone to just get an idea. I'm not going to comment on it just yet. So these are the caudal views. And here are the cranial views. So I'm just going to pause and ask our panelists just to give their opinion as to this angiogram.
Well, there is a moderate disease in the proximal left circumflex disease, and the LAD is severely diseased from proximal involving first diagonal as well. There's severe stenosis. So there's a bifurcation in the LAD with a severe stenosis in proximal LAD. The circ from that view, I think it's moderate, 50%, followed up by maybe aneurysmal left circumflex from what it looks like it here.
Yeah. Any other comments?
Very obvious that LAD diagonal bifurcation, this is the main concern, good size diagonal. And the main problem here, I just want to assess the ostium of the circ if there is any hemodynamic significant disease before fixing the LAD diagonal.
Yeah. And also, for me, when I did this angiogram, I was just wondering about this distal left main stem and some of the cranial views, you just wondered as well whether there's anything happening there. So just my understanding is we feel that there's something in, obviously the LAD is very tight, we know this. It's a very big diagonal, it's a very important diagonal, covers a very large territory. And there's this proximal circumflex. If you do the QCA, it might be a 60-70%, just purely to look at angiographically, which may also be significant. But if that's important, then it becomes a left main bifurcation or sort of a left main equivalent type lesion, right? So we did a pressure wire assessment of the circumflex before we proceeded with anything else. And my FFR was 0.97. And if I can just pause again, because we have a pressure wire assessment guru with us, just to give us his insights into this pressure wire.
So, Hani, I'm gonna stop you there for a little while because there's something interesting happening in your tracing. And one of the first things that you need to do when you put a wire in the coronary is don't look at the number. First, look at your pressure tracing morphology. The previous case that you showed, I forgot to highlight that. You have a very nice aortic pressure tracing with a necrotic notch. It looked beautiful. This one is not the case. Okay? Here what I can see is a little bit far from me, but I can see it from here. There is a ventricularization of your aortic pressure form, waveform. I see it clearly overlapping with your pressure Y signal. And I also see the reason. Your guiding is actually looking to the roof of your left main, and that is impacting your curve. So this FFR measurement, I think you should read it carefully. And the way to solve this is very simple. You just take a little wire and you disengage the guiding, you recheck that the morphology has changed, and now is the time to assess the FFR.
Exactly.
And so this will give you a falsely elevated FFR. So you may be missing true disease if you have a dampened waveform.
Yeah, so the way to remember that, yeah, because sometimes it's confusing, is the following. When you have, we're talking about mean pressures here. When you have the necrotic notch, the mean pressure will be pushed up. If the mean aortic pressure is up, then the ratio will be higher and the FFR will be lower. And exactly what you said. So here the FFR might be high and falsely high, let's say. Yeah.
Maybe I had a question about FFRing the circumflex coronary artery, like smaller territory of myocardium and so on. I rarely find it becoming positive unless it is like really a critical lesion. I don't know if you notice the same, if you want to comment about that.
I agree. I mean, how often do you pressure wire what looks like an 80% circumflex lesion and find out it's completely irrelevant, right? And that just reflects the size of the territory it supplies and the size of the vascular bed that's distal to the
But that, you know, just on that note, the circumflex, according to CT, covers about 40%, 30 to 40% of the myocardium. So, Carlos, you want to talk about this, the LAD work and what we found?
Yeah, so there are two things here, and you know, circumflex is the artery in the heart with most variable myocardial mass. So we have mapped around 500 cases undergoing PCI and measured the mass with a specific software from CT. The mass of the circumflex ranges from 10 to 12%, this very small circ, to 57. We have a 57 mass circumflex in the trial. That's crazy. And the reason why that is important is because what you just mentioned, the flow depends on the mass. And the flow is what drives the gradient, the FFR gradient. So the more mass, the higher the flow, the bigger the gradient. That's why the circumflex is so tricky. Now, what we just published with CIAD was the fact that when you measure fractional flow reserve, it is affected by the hydrostatic effect. In other words, if you have a completely normal LAD and the patient is lying down on the table, the LAD actually goes upwards in the horizontal plane. If you go upwards, your sensor is going to be around 5 to 6 centimeters above your guiding catheter, and that induces some error in the measurement. That error in the measurement is about 5 FFR units. So the normal FFR in the LAD in a patient lying down in the cath lab is 95. Cannot be higher. Cannot be 1, mathematically speaking. And that is very important. And exactly the opposite happened in the right coronary. Because when you're lying down, the right coronary goes down, and then you get the column of water influencing the pressure of the distal sensor, which is elevated. And I usually say to my fellows, they put a wire in the RCA, I said, listen, it's not well equalized. The FFR is 1.03. I said, no. That is well equalized. Normal. That is normal. The pressure distally is higher than the pressure proximally. So these are nuances, but I think the more we do, the more we understand these small details of physiology.
So what do you do in your cath lab? Do you move your sensors up and down? Or what do you do when you're doing these cases?
Well, I tell you what the Japanese, I'm going to go to the Japanese again. What the Japanese did, the Japanese put the wire in the LED and said, what? They asked the patient to sit down, and the FFR changed about 5 units. So
Somebody did
that's
that in
published.
London as well. They turned them upside down. You know that? Literally, so to change that, to prove the hydrostatic effect.
Oh, wow.
Right, so Carlos, you're going to give us a talk about serial lesion assessment.
So I will turn that back to you, Dr. Ziad. How confident, and Carlos again, so how confident are you to push for a lima for a 50% that was 50 focal? Let's, not the long, hazy lesion that FFR positive. No, it's a focal lesion that looks in your eye, it's like 40%, 50%. And then you found some disease in the circ, disease in the RCA, that's significant. And now you are sending the patient for cabbage. And the FFR is barely positive, is like something like 0.79 or something like this. Now, are you confident to send this patient for a cabbage with a lima? Or would you keep it? Would you say, you know what, I will just treat medically at that point and see what's going on? Because I've seen a lot of failure of lima. I don't know, like maybe it was missed FFR at that point. Maybe FFR was not done properly, and we are not interrogating the right results. Or is it something that you're not comfortable with as well?
Well, I mean, I think if you have a multi-vessel disease patient with a low syntax score, then the evidence suggests PCI and cabbage are similar.
Right.
And so usually when you're in that situation, when you have a focal lesion that's short, I'm really not referring these patients for surgery. I'm performing PCI. On that note, we always have to remember that ischemia is a continuum. While we like numbers, 0.79 versus 0.81 are not different enough, we need to make the decision on the treatment strategy based on that continuum. So we know that a patient with an FFR of 0.65 is much more likely to be impacted by treatment than a patient with a FFR of 0.79. And so all of these things have to take into account. And I'll leave this question to the panel. What if you have one lesion that's 0.65, or you have 3 lesions that are 0.79? What's the total burden of ischemia in that patient? Right? We never really look at the I mean, you could essentially add up the math for all 3 vessels and see what the burden of ischemia is for the whole heart. One thing that FFR has inadvertently done, or IFR has inadvertently done, is it's made it vessel-based instead of myocardium-based.
So just, I don't want to delay the presentation, but we have published something that we call the global FFR, which is the sum of the 3 vessels. And you're completely right. The lower the number is, the worse you will do. The higher the number is, the best you will do. That's with the FAME data. Good. So, Hani, you have a very nice case of, it behaves as serial lesions because you have lesion in the LAD, you have a lesion in the circumflex, the left main is shaggy, and I think it's important to understand what happens in serial lesions. And we're going to use, again, this type of model to understand how is physiology in serial lesions, and it's not complicated. So, the first thing we're going to do, we're going to put a lesion in the left main, okay? And this is going to be straightforward. Let's make everything focal to make our life easy. And we're going to measure the pressure at 3 points in the coronary. One in the left main or in the guiding, one in the circ, and one in the LAD. If you have a single lesion, this is what happened. The FFR in the circ and the FFR in the LAD will be both 0.8. Okay, this is the easy case. Now let's make things a little more complicated. Now, this is the case of, look what happened when you put a lesion in the LAD. When you put a lesion in the LAD, you are increasing the resistance at the level of the complete circulation. That means that the flow that is coming to the left main is going to be reduced. If the flow that goes to the left main is reduced, the gradient reduces and the FFR increases in the circumflex artery and decreases in the LAD. Okay? It's all about the flow. The lower the flow, the lower the gradient, and that is the reason why the FFR in the circumflex increases. And now let's do the opposite again for this concept to be clear. Now, what happens if we remove the lesion in the LAD? We're going to put a stent in the LAD lesion, and look what happened to the pressures. So we're going to alleviate the resistance. It means that the flow will increase again, and look at the FFR in the circumflex. It will go down, and the FFR in the LAD will increase. So, Hani, in your case, if you treat the LAD and becomes completely revascularized, the FFR in the circumflex will decrease. Why? Because the amount of flow that is coming in the left coronary circulation will increase because of the PCI.
That's very nice. That's very nice. Very interesting.
So I think just before I carry on, there's going to be a burning question in the audience here, Carlos. By how much? So if my FFR, and if I had a decent non-ventricularized pressure, and if it was 0.95 before I fixed the LAD, and I fixed the LAD, should it come down to 0.8? Should I have sent him to CABG in the first place, or is it going to come down by just a little bit?
That's a very good question. No, the FFR in the circumflex, if you, let's say, have a very critical stenosis in the proximal LAD, which a lot of flow goes through that, and you completely remove the stenosis, and you increase the flow, the most we have seen changes in the circumflex is about 5 FFR units. So you may go from, let's say, if you have a 97, the threshold was good, you will go max to 91. But of course, if you have an 82 or an 81, and you treat the LAD, that will certainly can go below the threshold of ischemia.
And I think that's important, because how often have we chosen to do PCI in multivessel disease based on a negative FFR in the other vessel when it's just been negative, it's just barely 0.81. I say that's good enough for me, I'm just going to go fix the LAD and leave it. Maybe we should think twice. Okay.
I'll take Abdullah.
I've been waiting since you were speaking about the, just sorry to go back a little bit. Now, CCS has been a problem for everyone, dealing with stable angina, so-called, in the past. Medication, PCI, then the people start to say that the way the PCI is done, that's optimum, we need imaging, we need physiology. Now we have this diffuse atherosclerosis, and now we're speaking about the PCI, maybe not the answer. Maybe the PCI is not the answer, the way we do it. The DS is maybe not the answer. Maybe we need to have a different approach for PCI. The way we can, this atherosclerosis has been building many years. So if we're able to, we don't want a cosmetic result on that day, which has happened over many years. On that moment, we want to bring it. So if we can do something natural, away from the, metals, in a way, of course, it has to be done a proper way, done slowly, gently. We are able to prevent future restenosis. We don't want the results. People talk about the DCB results, immediate effect. You will not get DCB results on that, in the cath lab. You will get it later on. People who have not have experience of DCB, it's difficult to talk about it because they maybe seen it, maybe heard about it. But if you've done this on your patients, especially the one you've spoken about, those diffuse atherosclerosis, and you've seen the immediate, in 3 months, I'm talking about that. This is my immediate. The angina is resolving, at least in my follow patients. Just talking about CCS, not about talking about the. So maybe, I'm not saying this is the answer, I'm saying maybe this is a better answer for diffuse. We should not say intervention is not the answer for diffuse. Maybe the DES is not the answer. Okay, maybe we need to, I'm just provoking thoughts, not, because this is what I've seen, at least my practice.
We'll take a point, Abdullah.
Maybe there'll be a trial for this in the future. Maybe. So we'll carry on with our case. So we started to do IVUS interrogation for this LAD. So we decided at that point that this is going to be an LAD intervention. The first thing I wanted to do is just get a better understanding of the anatomy so I can decide what I'm going to do about this. There's a lot of decisions to be made. How are you going to fix it? Do you need to be very aggressive with the lesion preparation? How are you going to deal with this bifurcation? Are you going to do it with a 1-stent strategy, 2-stent strategy, or something else? So if we orientate ourselves, we're going from distal to proximal, mid-LAD to proximal LAD to left main stem. I'm just going to let the IVUS run, keeping in mind I had to use a gentle dilatation with a 2mm balloon just to allow the IVUS to pass. So here we are, we're going more proximally, that will be the septal. And now we're going to see the diagonal coming in with the other branch. And now we're going towards the proximal LAD. And this is in the proximal LAD. So if we look at the, we also checked the left main stem. The left main stem was fine. Our MLA was 13, so I was quite happy that this is purely an LAD lesion that we're going to treat today. These are the images that we obtained throughout the LAD. So this is the more distal segment, the LAD diagonal bifurcation, and the more proximal segment. And we're going to go over these shortly. We then did an IVUS of the diagonal. And you can see different parts of the diagonal where we looked at what would have potentially been our distal landing zone around here. We've looked at this lesion over here. We've looked at the proximal vessel just distal to the bifurcation, and we looked at the LAD diagonal bifurcation. And these are the images that we got, and these are the sizes that we got. So if I'm going to pause here for a second and just ask Dr. Ziad to come over here and just analyze these irises for us.
Thank you. So, whenever we perform any type of PCI, we should be using the MLD max approach. So what we're trying to determine when we're looking at the morphology is really to determine A, whether we need advanced lesion preparation, B, how long the stent should be landing from normal to normal, not on the angiogram, but on the intravascular imaging, and finally the diameter of the stent. So let's see what we've learned here. At the distal vessel, this is obviously diseased and not a suitable landing zone. This is eccentric plaque, not a calcified nodule, as you can tell by its flat appearance, but also because of this gentle balloon dilation, what it's led to, like many eccentric plaques, is a dissection that is at the edges of the fibrous calcific interface. So now the calcium has been liberated and is pushing in on the lumen. At the sort of tightest segment, or at the site of the diagonal, you see a large plaque burden, which is consistent with the area of the necrotic core. That's also consistent with the highest atherosclerotic plaque and tightest lesion. And proximally, like Gary Mintz showed almost now, believe it or not, 25 years ago, what appears to be angiographically the normal segment actually has a very high plaque burden. In this situation, likely over 70%. So if we were going to go from angiographic guidance and place our stent from this red arrow to this red arrow, we'd be landing into a heavy amount of plaque with a high likelihood for dissection and a significant increase in target vessel failure. Let's go to our diagonal IVUS now, and again follow this MLD max approach. From a morphology point of view, we have what appears to be some eccentric calcium with multiple morphologies, but it's only on one side. Usually this can be pushed away with a balloon or stent. There does not appear to be excessive calcification otherwise, so this is going to be our area that's likely going to lead to the underexpansion. Now, distally, again, we see an area where there's a large burden of atherosclerotic plaque, but there may be no place that you can suitably land this stent. So what you're going to look for ideally, we call the green light zone, is a plaque burden less than 30%. The amber light zone is 30 to 50%, and greater than 50% is really an area with high risk of dissection and high risk of target vessel failure. Again, as we pull back, what else do we notice? We notice in the proximal diagonal a large plaque burden and the left main coming in, suggesting that if we're going to perform PCI, this will need a dedicated two-stent strategy, which fits with what we were talking about the bifurcation strategies earlier. A very long vessel, more than 73 millimeters, a vessel that's probably 2.5 millimeters of diameter or larger, and is the first diagonal, so covers a large amount of territory. So this could be one approach.
Very nice.
Thank you. So carry on. As Ziad said, we had to identify decent landing zones. So we go back and forth in our IVUS to just try and find how long is this lesion and how short can we be with our stents. We've identified our distal landing zone to your left and our proximal landing zone to your right. And you can see from our distal landing zone, it's about 2.6 millimeters in diameter. So 2.8 one way and 2.5 one way. Proximally, the healthiest segment I can go without going into the left main had a lumen diameter of about 3 millimeters and had a black burden of 48%. So we either decide we're going to agree with this or we go all the way back to the left main. And in this case, we didn't want to go back to the left main. It's below 50%. Now, obviously, the length is about 35 millimeters. We don't have 35 millimeter stents. So what we do is we extend our distal landing zone to 38 and do another measurement, which in this case was 2.5 millimeter. So we thought, well, okay, we don't need aggressive vessel preparation. We could just dilate with a normal balloon or a normal NC balloon at relatively normal pressures. We'll take a 2.5 38 just for this LAD. And obviously we need to go up to 3.0 in the proximal LAD. But what about the diagonal? Well, the diagonal for us, if you looked at the previous image, the lumen itself is barely 1.8 millimeters. And yes, you can go in terms of media to media and upsize it, but distal to your stent, you're going to have a very small MLA in a relatively small caliber diffuse disease diagonal. And the worry here is you can make it look beautiful on the day, but you come back a couple of years later, and is the diagonal going to remain patent or not? So what I actually did was I treated the diagonal with a DEB. I took a 2 millimeter DEB at a nominal pressure. I didn't go excessive because of this calcific area could potentially dissect, and I didn't want to cause a flow limiting dissection. And then we treated the LAD with a 2538 stent, post-dilated just proximal to the edge with a 275, and then used a 3.0 for a pot. I didn't even recross, and I didn't do a kiss. We repeated our IVUS post-PCI, so you'll see that there's no proximal or distal edge dissections. We looked at our references and we looked at our expansion limits, so is it not? Okay, good. So we looked at our distal references, the proximal references, no edge dissection. Our expansion is over 100% both proximally and distally, so I'm quite happy with the expansion apposition and the fact that there is no edge dissection. We repeated the pressure wire assessment post-PCI of the LAD, and our FFR is 0.9. What do we think of this waveform here, Carlos? Is it acceptable or? Yeah. So our FFR now is, is 0.9, and this is the final angiographic result. So we need, we've got quite a lot of experience on this side, Ziad, with using DCBs. We've been using them for quite a few years. And I'm using it more and more de novo now than I was. We started off using it just for ISR. Now we're using it a lot of de novos. And what we found is you bring the patient back 6 months, 12 months, and the vessel grows, it remodels. And we've stopped looking for this beautiful angiographic zero stenosis result. We just want a good result with TIMI 3 flow, and quite often the patient will do well.
And I think this is an unanswered question in interventional cardiology, and is the topic of a lot of discussion about the use of a drug-eluting balloon for side branches, which may be additive benefit in terms of a provisional approach.
I will ask actually Dr. Ziad Ali at this point, since DCB is coming and imaging is evolving, how much dissections, how much lesion you are happy to leave at the end of the case when you do a DCB and not to stent that lesion, especially for osteal lesions?
Yeah, that's an excellent question, and I certainly don't have the answer. I think we all recognize that the mechanism of balloon angioplasty is indeed to create dissection by definition, so we'll have to learn using serial intravascular imaging studies which dissections actually heal and which don't. Typically, at least at the moment, the length of the dissection is what dictates your likelihood of failure. It's not actually the arc of the flap. Okay. So now, unfortunately, the ROC curves that length of dissection is relatively short, 13 millimeters or so. So if you have that length of a dissection, it's likely to heal poorly.
So this is just a separate comment on the topic, but I think that there is, in the GIS, I've heard that there is an appetite in all the region for doing research. And what I have seen more and more, and I do the left, but here the use of drug-coating balloons yet is very, very high.
Yes.
So in the US, they cannot use it. In Europe, we're a bit shy. Here, it's skyrocket high. Japan is an exaggeration. So, but we see this trend, and one of the things that perhaps is going to be a very important question is what you made, and I think you, with the practice that you already are doing, OCT plus DCB, can help us answer that question.
You know, I would also say on that note that perhaps the modality to assess the acute result is a physiological result rather than an imaging result, right?
Yeah. I think what's driving people shy is what you actually wrote in what's acceptable results post-PCI from the MLD max. And they are using the same phenomena of, how long is the dissection, what's the depth of the dissection. And it's created confusion of what to acceptable to leave after the case.
Yeah, so I'll make a very important disclaimer there, and that is the length of dissections which are at the edges of the stent have an entirely different flow pattern than the edges of a dissection in a drug-eluting balloon, right? Yeah. Because what you're doing is you're creating a high flow system that leads into a pocket. And so then the flow wants to go into the pocket to further extend the dissection. That doesn't happen with a drug-coated balloon or, in fact, a CTO dissection, because the blood doesn't really care which path it takes. It just can't have a blind ending tube. If you have a blind ending tube, it creates a hematoma. If you have multiple dissections, which we leave in CTO all the time now, as long as there's flow, the artery will maintain patency.
Like, that's an important point, because I find flow is a key metric to watch, because if there is very good flow down the artery, even though there is a dissection and so on, such lesions are safer to leave compared with others. I want to go back to the point of FFR. One take-home message for the team is good to actually redo at the end. I think it's a common mistake, or maybe us being lazy where we don't redo at the end, or when we have a question, it's good to actually redo it after you fix the lesion if you still have a question in mind. So.
You know, I often, Antonio Colombo sort of leads the field with his risk permissiveness, and he's been using FFR post after doing very long segments of DEB and seeing an acute result of 0.80, he'll leave it. And while at first I thought that was absolutely crazy, now I understand the potential value of that acute result in terms of acute closure. While that doesn't answer the question of how it's going to remodel, it certainly does answer the question as to whether there's enough flow to prevent flow limitation in that artery acutely for abrupt closure.
Please, Alex.
Okay, so we have in the monitor 6 minutes. We're supposed to have 15, but that means that the discussion is very rich, so we're happy.
You take whatever time you need.
Okay, thank you very much, Agnes. So we're going to do a second case, and this case is quite interesting. We're going to shift now a little bit to OCT, and you're going to be surprised of the images that we're going to show. We were. So let's go very quickly to the clinical characteristics. This is a 70-year-old male patient. You see the baseline characteristics of the screen, symptomatic, positive non-invasive test. This is one of the things that we're doing more and more, which is preparing the case, understanding the burden of calcium. This is a CT, a coronary CT, showing that we're going to treat a high burden of calcium with some concentric calcification in the mid part of this LAD. I'll show you the angiography. This is how it looks. So not so impressive in the amount of calcium that we see, but we would like to confirm that, of course, with intravascular imaging. I'll show you the still images. This is the lesion that appears to be the more severe and responsible for the symptoms of this patient. We put a pressure wire down the vessel. FFR is 61. And then we do the pullback. This is hyperemic pullback. PPG is 54 with a clear pressure gradient in the mid portion of the vessel. So this is a case that benefits from PCI in terms of the disease pattern. We tried to do OCT. The catheter didn't cross. Okay? Welcome to real life. Okay, good. No problem. Let's balloon it and make some room for the OCT catheter. Look at the balloon. After a few attempts, try to cross the balloon. We cross it. We cannot really open that particular part of the vessel that we knew already by the CT there was a very calcific lesion. Then we very quickly shifted to rota. We saw this undilatable lesion. We rota the vessel, and that was kind of the way forward in the case. Now we were able to do OCT. Okay? So this is the run in the OCT from distal to proximal. You see the co-registration above. You see some of the details about the calcium angle and the maximal thickness of the calcium on the screen. But in the next slide, I'm going to ask Siad to help us understand what he sees in these OCT, post-ballooning, post-rota. And Siad, if you can start with cross-section A, that would be great.
Yeah, so fantastic. This is a great example of how to incorporate MLD all into one pullback. So what you see at A and in fact E is two sections where you're able to visualize at least 180, if not more, degrees of external elastic lamina. Whenever you're able to see this amount of external elastic lamina, it's essentially telling you that the artery is mostly normal and has plasticity to it. So when you land your stent in it, it's got some rubber bands on it to allow it to expand. Now inside that, at B, you have a dissection, right, which is the mechanism of the balloon preparation. And at C, you have very nice calcium fractures. At D, you have unprepared lesion. You'll notice that there's a segment of calcium. Even though we spent a lot of time and energy fracturing this, there's a section of calcium that has not yielded, and at E, there's another calcium fracture. So the focus before placing a stent must be lesion preparation in segment D because of the risk of underexpansion.
Excellent. And, you know, we saw this cross-section D and we said, okay, we have to prepare that case better. So this is the decision we took. We took a cutting balloon at 3.0. You see again that with the cutting, it was not possible to break the calcium. Then we shift very quickly to an OPN, and with very, very high atmospheres, we were able to expand the balloon, meaning that the calcium was cracked. Immediately, there was a propagating dissection in the vessel, so the patient became symptomatic, so we decided to go to stenting immediately. You see how difficult it was to put the first stent. We put a 48 to start. We already knew the distal landing zone, and then we complete the PCI with a 33 millimeter stent. This is the final angio, which looked acceptable. And then we were, of course, now confirming the result both with physiology and imaging. So I'm going to show you now the post-PCI OCT run, and this is what we found. I'm going to let it run for you to understand the disease that we treated, and again, the acute results after placing these two stents. And you see here, there was the point of maximal calcification. You see there what happened. You see the automatical expansion provided by the Ultron. And then you see here the proximal part of the vessel. And Siad, I'm going to ask you again to help me understand what happened and what is the morphology that you see now in the post-PCI OCT run.
Great. Okay. So what you see at sections A and E are the proximal and distal edges. So this is the M of MLD max, so for medial dissection. You just go outside of either of these frames to determine whether there's a flap. You'd want that flap to be less than 90 degrees and less than 3 millimeters in length for you to be able to treat it conservatively. What you'll notice here in terms of, we don't really have the A for apposition, but from what we can see, there's no gross malapposition, but the expansion seems to be impacted at section C and section D. And there's two important points here. One, you'll notice that eccentric calcification frequently leads to this D-shaped stent, right? The D-shaped stent happens because you create a tear between the calcium fibrous interface, and that tear is held open, but the radial strength is always impinged by the calcium on the opposite side. Fortunately, your minimal lumen area is good. What's a little bit more concerning is cross-section D. Cross-section D is a protruding calcific nodule, okay? Now you'll notice that the nodule is already starting to protrude through the struts. Once this happens, you have a 20% 2-year target vessel failure rate. Because as the artery continues to move, the nodule continues to push in and impinge, and the mechanism of failure here is reprotrusion into the lumen.
Good. Thank you, Siad. That was fantastic. We're going to go back to that point, but before that, I'm going to show you that the patient started with a very low FFR. The post-PCI FFR in this case was 85, and when we compare the pre and the post, this is what we obtained. So we really improved conductance in this vessel. Beyond the appearance of the calcified nodule, we're going to go back to that point. You see here that the FFR increased from 50 to almost 90. So we were happy with the functional result at the end. But Siad, it would be great if we can learn more of you about calcific nodules at this moment.
Sure. Do we have time?
Yes, we do.
Okay.
5 minutes.
5 minutes.
Good. All right. So this is a pet project of mine. If we could put the slides up. So calcified nodules have somehow appeared from out of nowhere and now are a huge part of our practice. So about 5% of all acute coronary syndromes are caused by calcified nodules. And really there are two types. And as you all know, I pride myself on being pragmatic, and I'll continue to do that. So there's a protruding calcified nodule. A protruding calcified nodule has a very smooth shape to it. So what it basically looks like is the side of a marble. All right? Smooth. And then you have an eruptive calcified nodule. So what an eruptive calcified nodule is like broken glass sticking out of a pillow. So a protruding nodule is like a marble inside a pillow, and an eruptive nodule is like broken glass filling out into a pillow. Why is that important? When you have broken glass, i.e. an eruptive calcified nodule, you can consider that lesion to be already prepared. The fact that it is broken already is similar, analogous to creating multiple calcium fractures with shockwave, for example. So eruptive calcified nodules are almost always deformable. If you go and see an eruptive nodule, you put a balloon on top of it, it will get pushed out of the way. Because the only thing that surrounds the eruptive nodule is lipid and blood. Okay? A protruding calcified nodule is unfortunately a different entity. And the reason for that is you don't know what's underneath this marble. It could be blood, it could be lipid, or it could be rock. If it's rock, you're going to have an unexpandable lesion. If you have lipid, the nodule is simply going to get pushed away. So the right way to manage nodules when you see them is to use a 1-to-1 appropriately sized balloon to see whether or not the nodule is deformable. So the concept of deformability of nodules is critically important. Remember this, eruptive calcified nodules are active. They're like ACS, right? They're hot plaques. So they're easily deformable and modifiable. But protruding calcified nodules are passive, like calcium, like boulders, like rock. And so we need to think of those in those two concepts. What usually happens with an ACS? Your stent expands beautifully, you push the plaque out of the way. What happens with chronic coronary syndromes that are heavily calcified? Lots of lesion preparation, a lot more work goes into them. What we do know is that if you have a calcified nodule versus not, you do much worse. And the main reason for this is either, as Carlos showed very beautifully, reprotrusion of the calcified nodule, which unfortunately happens most commonly with eruptive nodules, but also because of redevelopment of nodules in other areas of hinged portions of the coronary artery. Thank you.
It was perfect. That's very good.
So I've got a small question while we're coming in. So in this case, say we were to come across something like this, and there's a protruding nodule into your stent. What can you do?
Well, the first strategy we suggest, of course, is to do more balloon dilation. Part of the reason the nodule reprotrudes is because in the areas of nodule, there's 4 times the amount of calcium. So what you're doing is you're basically scaffolding the nodule with 2 rocks on either side. So A, high pressure balloon dilation. B, there may be some utility to post-PCI intravascular lithotripsy to try to break up the marble into pebbles. That may provide you some benefit. And then lastly, could be, but we don't know, is maybe a stent with more radial strength, focal in that area to try to push the nodule out of the way. Remember, the footprint of a contemporary DS is only 18% now.
I think a key point is to try to avoid initially stenting until preparing the lesion as much as possible. And I wonder about orbital in such cases where you can actually shave more into the, compared with the regular rota, or using a higher size, bigger size rota bursa.
I was just speaking with this about Mohammed just a few minutes ago. So we did that study. In fact, I just submitted the abstract today to CRT. So the amount of debulking that happens with orbital atherectomy is unfortunately and sadly very low. So at the maximum calcified nodule protrusion, the amount of debulking that's created by orbital atherectomy is 11%, not 50%. So the analogy would be you are basically cutting the top of the Himalayan mountain off. And then because we're not imaging serially and we have limited further options, what happens is we go in with the orbital, create a big orbital and stick a stent. But the lesion is not prepared at all. We don't have great methods to treat these lesions. What data we have is that rotational atherectomy patients who have calcified nodules do 3 times worse. And what data we have from IVL is that at least right now, the patients who have IVL with a calcified nodule have the same minimal stent area at the end of the procedure as those patients without calcified nodules. I don't think that's a direct effect on the nodule, but it's the impact of the IVL on the calcium that surrounds the nodule, allowing you to push the nodule out of the way and liberate the vessel.
So another small question, sorry. Say you're in this scenario now, and some people say, I'm going to take an OPM balloon and go up to 35 atmospheres. How safe or unsafe would that be? Are we likely to perforate something at this stage?
I will tell you, we use OPN every time after I use OPN, I go 35. The next contrast injection, you take a deep breath, you do the contrast injection if you don't see extravasation, but you have that fear.
But your question is a great one, and it goes back to the concept that I talked to you about before, which is you cannot see beneath the shadows on intravascular imaging. So you don't know if your marble is sitting on top of rock or your marble is sitting on tip of lipid. If your marble is sitting on top of lipid, you go to 35 atmospheres, nothing will happen. Because the marble will just push into the lipid and squeeze the lipid around it. But if your marble is sitting on top of rock, at some point the rock will penetrate the adventitia. And we have all seen those cases where you see a little adventitial contrast after dilating these lesions. And that is basically telling you that your calcium is now penetrating into the adventitial layer.
Personally, maybe in that case, I would use 1.5 rota. I think you use 1.25 initially, and then maybe I'll upgrade to 1.5, and then maybe.
But even the same problem, because if you think about the relative contribution or impact of a 1.5 burr on where the calcified nodule was, the artery had a minimal lumen area of 6. So what happens is the nodule's on 3 o'clock, your wire bias is at 7 o'clock, and the nodule just basically sits here and your burr just swings right past it. So real impact in those cases is really big burrs, like 2.0 and 2.25 burrs.
We'll take a question then.
Yeah, thank you. So just a quick question. So the higher target vessel failure or target lesion revascularization with a protruding nodule after stenting it is not related to the MLA at that area? I mean, if we can reach a good MLA, is it just because of the abnormal shape of the vessel?
That it's the hinge motion. So where do nodules happen? So let's talk for 2 minutes about why nodules form. In order to develop a nodule, you need a really big necrotic core, okay? So you have a big pool of lipid, the middle of the lipid dies, right? There's no blood going there and cells can't penetrate it. So the body thinks, this is bad, let's try to kill it. The first thing they do is they send more inflammatory cells to that area. They can't kill it, and the natural reaction of our body in all situations there is to wall it off, right? First, they try to calcify the cells themselves. They realize they can't do it. Then they create a big calcified segment around the calcium, okay? So that's, and then that type of calcium, which has almost no collagen in it, is like an egg. So if you catch the calcium at that point and you use cutting balloon, IVL, rota, you're gonna break the egg, the yolk will spill out, your stent will expand beautifully. The problem is when that calcified nodule starts to have collagenized calcium in it, now it's concrete. And that's where you need the atherectomy to be able to sort of burr into it and create cracks. The trouble is that, and we've done this study, by OCT you cannot tell. Because once you create the eggshell is the rate limiter for the refraction of the light. Maybe by CT, we may be able to see it by the density by Hounsfield units, but we haven't been really great for calcified nodules in that area either.
That's, I think, to be honest, I'm enjoying that session so much that I don't want to conclude myself, but I'm learning myself a lot today, especially with flipping the patient downward. That was something. Yes. One last question, then we will conclude that.
Question and comment. Say, this like a nodule. So I'll just discuss my case. I did one and prepared it by directional atherectomy, and not directional, what you call CSA.
Rotational?
CSA, what you...
CSI, orbital atherectomy, yep.
After that, we thought it's enough preparation. We just put a proximal LAD and dilated, put the stent, did not expand fully. The nodule did not open fully, and we were worried what is to be done. So next step, we were thinking we can do IVL, but as such an acute stent, it is not really indicated. Does anybody have any experience that can it be done in this situation, or what are the alternative if you have done stent at this stage?
So we published that data in JACC Intervention this month. We did acute imaging of scanning electron microscopy and surface metroscopy of stents that underwent IVL, and the amount of damage that happens to the stent is very small. 7% of the entire surface area of a Xience, 5% of the entire surface areas of Medtronic, no damage to the polymer of Synergy because there's no polymer, and 2.5% of Megatron. So if you're stuck and you need IVL as a bailout inside a stent, you can do it safely.
Another point, one of the times which you were mentioning about the FFR, and if you have a lesion, suppose proximal LAD and very distal near the apex of LAD, you have got lesion. So in my own experience, I had once, I left the distal lesion, thinking it's too small a vessel, doing something, it may dissect and you can not repair at that point. It ended up causing a restenosis in proximal area. So do you have any, explanation for it or any experience or anybody?
Well, I think when you think about physiology, every case is different, but let's say that you have a very distal lesion without any diagonal branch, and then all the flow is going to the distal LAD, and you have a very tight lesion distally, that would certainly reduce the flow in the distal LAD and might influence all the hemodynamics related to the stent. So yes, that could be the case. If you have a big diagonal, the flow will be shifted toward the other side, so that it's a different scenarios, but yes, what you say, it's plausible. So, Ahmed, I think that we have a wonderful session because we have these big important tools in our armamentarium, which are physiology and imaging. And the more we use it, the more we understand them. And I think we have tackled the two main big areas of uncertainty, which is one, diffuse disease using physiology, and second, calcified nodules using imaging. So I think it was beautifully demonstrated in both cases. I think it was a fantastic discussion. Do you have any final thought before we?
I enjoyed every moment of the session, to be honest. You guys learned from you before and still learning from you. A local expert as well added so much to the discussion. Thank you for Dr. Ashraf, Adil, Dr. Hani. I enjoyed preparing the session with you for a couple of sessions as well. Fawaz, unfortunately, he couldn't join us. Carlos, we really enjoyed your presence as well as Dr. Ziad, who learned from past and is still in the present. Thank you very much for the session. We can take a picture of all of us together.